request any one of you to please stop me any point, anywhere. Okay, please stop me any point, anywhere. I will not move further. I will just talk to you. It's a little complex topic. I will try to simplify as much as possible. And in another 30 minutes or so, we should be able to do our job. But please stop me whenever you want. Where is the second pen, black one? Okay, we have this. Great. Can we move this in the center? You can move it in the center. Okay. So, yes, ma'am. Thank you. So, we all understand that spirometry. We all understood spirometry? Yes or no? बोलो यार, मुझे मालूम है भूख लग रही है, लेकिन उसके बावजूद भी बोलो यार. जितनी तुम्हें भूख लगी उतनी मुझे भी लगी है यार. इसका मतलब थोड़ा ना बोलोगे नहीं. And I know that I am standing in part of place where people understand Hindi also. I am not in that place where people do not understand Hindi. हाँ बोलो, spirometry समझ में आ गया सबको? नहीं आया? आ गया, very good. तो spirometry बड़ा आसान है. Very easy. Very easy. Yes or no? Yes sir. Very easy. Very good. पक्का? अभी spirometry station पे करने को बोलेंगे. So spirometry, yes, it's a very beautiful procedure, no doubt about that. It is the standard procedure across the world, no doubt about it. But whenever you are doing on the bedside, then at that time you will face so many difficulties because it is a forceful procedure. Now try and understand. Sir, कुछ urgent नहीं है तो बाद में बात कर लें. Sir, कुछ urgent नहीं है तो बाद में बात कर लें. Is it okay? हाँ, क्योंकि यहाँ पे अगर starting से हम छोड़ देंगे तो मुश्किल होगा. Spirometry is a forceful procedure. When it's a forceful procedure, then at that time, many times it becomes difficult. I will give you my example. I came back from UK in 2014 and I joined Gangaram Hospital. When I joined there at that time, I am basically a pediatric intensivist. When I joined in pediatric intensive care, I was working like 12 hours, 14 hours in a day, and then night calls also. In the initial 5, 6 months, 7 months, I was so tired that I was thinking that what is happening? Probably I am working so much, the people are taking so much work, private hospital, so that might be the reason, intensive care and everything, okay? Then one of my fellow who has recently got tuberculosis, pulmonary tuberculosis, I thought that I might have caught up something and that is why I'm feeling so much tired and I'm like very weak. So I went to the physician in the hospital and I asked him that, okay, please work me up for the tuberculosis. Then he told why. I told him the symptoms. He asked me, okay, you do one more thing, you go for spirometry. Why? I do not have any symptoms. I am just having weakness, I am very tired. But otherwise I am okay. I am not having any breathing difficulties or something like that. Oh, you do this also, no problems, okay. So surprisingly, all my tests were normal. Tuberculosis tests, everything was normal. My spirometry, my FEV1 by FVC was 54%. Right? That was 54%. And with a very good reversibility of nearly 25%. I started on inhalers. 3 months, 6 months later, I was absolutely okay. I was perfectly okay. So what I'm saying is that this asthma can actually present with a varied symptoms also. It need not to present with a typical symptom, one. The second thing is that when I performed spirometry, and on that particular day, I came to know that how difficult it is. It is not that easy. Right? When we are speaking here, it is not that easy. You have to really take a deep breath in and then deep breath out. And that deep breath out is actually very difficult. Okay? It is not that easy. First breath is still okay. When you are doing it for the second time and the third time and then subsequently, you get progressively tired and ultimately it becomes difficult. Okay? Then, now think about children. 5-year-old child. Very difficult. You will not be able to produce it. 3-year-old child. Very difficult. You will not be able to do it. Now there are certain other cohort of children in which, like for an example, neuromuscular disorders, Duchenne muscular dystrophy, Down syndrome children, autistic children who are unable to follow your commands. They are unable to because their neuromuscular results are not good. So it actually becomes difficult. So can we think about some other test? Can we think about something else which is not that labor intensive, which is a little easier one? So here comes the concept of oscillometry. What is oscillometry? Oscillometry is based upon sound waves. What are these sound waves? Everywhere now the world is moving towards ultrasonic waves, ultrasound. In the ICUs also, you will see that we are now using ultrasound probes so much. Even the chest ultrasound we are doing, we are keeping the probe anywhere, top to bottom, and we come to know. A child comes to us with intensive this raised ICP. We put on the optic nerve sheath. Optic nerve sheath diameter, we see that what is the diameter, and we say that okay, this is intracranial pressure high. We do not require CT scan. Similarly in the chest, similarly on the heart, similarly in the abdomen, similarly on the joint, similarly anywhere. You just put the probe and you see. So same way, oscillometry is based upon the sound waves. Okay. So what we are doing here, the person or the patient or the subject, he is breathing on the tidal breath. Like you all are sitting here, you are just taking the breath in, out, no forceful maneuver. In, out, and on the top of that breath, we are passing the sound waves. Now these sound waves are going along with the breath inside and then coming out. So what is happening? Let's see. For an example, so this is the person. The breath is going in normally, right? Going to the lungs, and then during expiration, the breath is coming out. This is the normal cycle of the airflow. So let's assume that the airflow is happening like this. Okay, there's a tidal breath, normal airflow which is going like this, perfect. And now what we are doing is, we are using a loudspeaker which is called as a machine, which is called as loudspeaker. So this is a loudspeaker here. Now this loudspeaker is producing certain sound waves. Now these sound waves are riding over this airflow, riding over this tidal breath like this, sound impulses, and along with the airflow they are going in and then they are coming out. So during inspiration they are going in, during expiration they are coming out. When they are coming out, then at that time, here in this path, there are two transducers. One is a flow transducer, another is a pressure transducer. So directly, whatsoever changes are happening from inspiration to expiration, these transducers are picking them. And they are directly measuring the pressure and the flow, because there are two transducers, pressure and flow. Pressure transducer and flow transducer. Okay? Later on, by Ohm's law is resistance is equal to pressure divided by flow. So later on, by using Ohm's law, machine calculates resistance, and that is pressure divided by flow. So pressure and flow are direct measurements. Resistance given is the calculated or the derived measurement. Am I clear here? Correct? So this machine will give you the resistance value, that what is happening in the resistance. Let us try and compare the differences between spirometry versus oscillometry. Listen very carefully. First, spirometry is a forceful maneuver. Difficult. Oscillometry, tidal breathing. Going in, coming out. Perfect, no problems. Second difference. Whenever you are taking a normal breath, right now, this is a laminar flow which is going on. You understand laminar flow? Laminar flow which is going on. Laminar flow means every direction, every flow direction is going in one direction. Like this is laminar flow. This is laminar flow, okay, which is going in. Whenever you are asked to do a forceful breathing, then at that particular time, the turbulent flow happens. Now the direction of the each wave differs. It moves in several different directions. This is called as turbulent flow, okay. So whenever you are breathing in the laminar flow and whenever you are breathing in the turbulent flow, the resistance differs. Spirometry is a non-physiological breathing maneuver. It is a forceful breathing maneuver. Normally, we are not breathing forcefully. Normally, we are breathing tidal breathing. We are having symptoms. Patient is having symptoms at tidal breathing. He is not having symptoms when he is doing the turbulent airflow. Are you getting me? And we are trying to assess it by a non-physiological maneuver, which is spirometry, which is a forceful breathing maneuver. So forceful breathing maneuver or spirometry is not a physiological maneuver. It is a forceful breathing maneuver, which is against physiology. When it is not a physiological maneuver, how it can detect actually physiological changes, still have it out. We really don't know. 3. Whenever you are doing spirometry, then at that time what you are measuring? Doc Sahab has told you. What you are measuring? Bolo yaar. Volume and flow. Correct, na? Volume and flow. You are not measuring resistance. So volume and flow are the surrogate markers of resistance. So when you are measuring volume and flow and with some percentages of 30, 50, 80 or 60, 80 whatsoever, then at that time you are saying it's a mild obstruction, moderate obstruction, severe obstruction. But this obstruction is actually, you want to say, resistance. And resistance is a surrogate marker, or the volume or flow is the surrogate marker in spirometry for resistance. You are not directly measuring resistance. Here in oscillometry, you are directly measuring resistance. So it's more physiological maneuver. You are directly measuring resistance. Am I clear till here? Should we move further? Okay. So when I was talking about sound waves, there are two types of sound waves, or two frequencies of sound waves. So when the sound is moving, so the unit of the sound wave is frequency, correct? Unit of the sound wave is frequency. So we are commonly using 5 Hertz and 20 Hertz. What do you mean by 5 Hertz? Sir, what do you mean by 5 Hertz? बोलो यार. 1 second. Yes. जब तक सही नहीं बोलते मुझे सुनता नहीं है. 1 second, 5 seconds. Correct? So 5 Hertz means 1 second, 5 waves. Correct? 20 Hertz means 1 second, 20 waves. Perfect. Very good, audience. What is the relationship between frequency and wavelength? Inversely proportional. So frequency is inversely proportional to wavelength. That means smaller the frequency, more the length. Perfect? Got it? So this is the airwave. Smaller the frequency, 5 Hertz. 5 Hertz is a smaller frequency. More the length. Larger the frequency, 20 Hertz, lesser length. So larger frequency, lesser length, 20 Hertz, 5 Hertz. So 5 Hertz will be able to tell you the resistance or the property of the entire airway from top till the peripheral airway up till the alveoli, whereas the 20 Hertz will be able to tell you only the proximal airway, only the large airway. Is it okay? Concept clear? Concept clear? Should we go further? Okay. What is the definition of small airway? यार मरमर नहीं करो, थोड़ा तेज से बोलो ना. Definition of small airway नहीं समझ में. हाँ तो ठीक बोल रहे हो, बोल ठीक रहे हो, पर थोड़ा तेज बोलो. सही बोल रहे हो. 2 millimeters. 2 millimeters is considered to be cut off for the small airway definition. Right, great. Okay, now coming to oscillometry. So oscillometry, you understood what is oscillometry? Oscillometry is the sound wave which is traveling over the tidal breathing, coming out, signals are transduced, resistance is calculated. Correct? Should we move further? How many types of oscillometry are there? What is the complete name of oscillometry? Complete name of oscillometry is called as FOT. FOT is forced oscillation technique. That means when the tidal breathing is going in, at that time the sound waves are forced over it. This is called as forced oscillation technique. FOT. Correct? Now there could be 3 mechanisms by which FOT can work. First mechanism. You sent one frequency inside, 5 Hertz, like this. Then 5 Hertz went in, came out. Then you sent another frequency, came out. Then you sent third frequency, came out. This is called as mono frequency. So first type of FOT is mono frequency. One sound wave, one time, going in, coming out. Best mode, no doubt about that. Right, it's a best mode, best characteristic identification. The problem is that time consuming. You will take initial few seconds for first wave, then second wave, then third wave. So it is more time consuming. Right? We want to keep the things shorter because we do not know that for how long the child will cooperate. So that is why we want to keep the time shorter possible. So this is the problem with the mono frequency. Can we do something to do the things faster? Yes, we can do. What we can do is that let us combine the waves together. Let us send few waves together inside and then come outside. Okay? So 5 Hertz is going inside. 5 hertz is going inside, right? And on the top of that, simultaneously, we are also sending 20 hertz. In between, there are 10 hertz also, 15 hertz also. I'm not complicating the issue, keeping it simple. That's why we are sending 20 hertz also. What is mean 20 hertz? Right, correct? So 20 hertz is going inside. Perfect, very good. That means 2 waves are going inside together, or many waves are going inside together and coming out, time saving, time saved, correct? This technique is called as IOS, impulse oscillometry. So many times IOS and FOT are used interchangeably. It's wrong. The basic technique is FOT, that is the mother tongue. IOS is a type of FOT. Okay, but usually people say take it interchangeably, that's a separate thing, but it's a type of FOT, right? So IOS means you have combined 2 waves together, small wave and larger wave. Very nice technique, very good technique. Very good technique because it is saving you time. Problem is superimposition. So this 20 hertz wave is getting superimposed over the 5 hertz wave. 10 hertz wave is getting superimposed on the 5 hertz wave. 15 hertz wave is getting superimposed on the 5 hertz wave. Superimposition. When there is a superimposition on the sound waves happen, then at that time the characteristic measured by the 5 hertz is hampered. So the values given by the 5 hertz wave are not that accurate. And that is the main problem with the IUS. So this is the main problem with the IUS. So very good technique is mode frequency, more time consuming. Very good technique is IUS, less time consuming, but the 5 hertz readings are not that great. Can we do something else? Any idea? Can we do something else? बोलो please यार. भूख लगी है तो ब्रेक कर लेंगे बीच में. बोलो. So let's do something else. Five hertz, and then use another frequency which is not a multiple of 5 hertz, which is called as prime number. So use prime numbers. What are prime numbers? Which cannot be divided by any other number except by 1 or by themselves. So 5 hertz, 7 hertz, 11 hertz, 13 hertz, 17 hertz, 19 hertz, 23 hertz, these are the prime numbers. 31 hertz, right? Now what is happening? You are using multiple waves, 5 hertz along with probably 19 hertz or probably some 13 hertz or something like that, or 17 hertz. So this is the technique in which you are able to send the multiple sound waves simultaneously inside, coming back. So time you are saving, and the advantage is that nobody is overlapping anyone. When nobody is overlapping anyone, then at that time, no wave characteristic is hampered. The name of this technique is called as PRN, pseudo-random frequency. So PRN is a third type of FOT, which is called as pseudo-random frequency. So if somebody is asking you that which is the best FOT, is the PRN. PRN is the best. So many conventional machines which we have, they are using 5 hertz or 20 hertz or 5 hertz or 19 hertz. So if it is 5 and 19, then they are working on PRN, which is a little superior as compared to 5 and 20, which is working on IUS, which is a little inferior, but the values or the difference is very non-significant type of thing, so don't worry about that. Is it okay? You understood the basic? Should we move further? Now, in the respiratory system, the entire respiratory system from top to bottom, when the resistance of respiratory system is called, in oscillometry is called as impedance. So the name of the resistance is called as impedance. Impedance is also denoted by Z. So this is called as respiratory impedance. Whenever you are going in the forward flow, when the flow is going forward, you are taking air inside and something is obstructing it. So what is that? That is resistance. So in the forward flow, whenever it is encountering something, this is called as resistance, which is denoted by R. So this is a process of energy expenditure. When the air is going inside, then at that time it is encountering certain resistance, certain obstruction. So whatsoever obstruction it is encountering, that is the process of energy expenditure. This is resistance. And when the lungs have inflated up till a certain stage, and the recoil back is happening, this is because of the inertial moment, inertia which is happening. So this is called as reactance. So it will depend upon your compliance of the lung, your inertial properties of the lung. So this is called as reactance, which is denoted by X. So it is not a simple mathematician plus, but yes, it is a combination of resistance and reactance with some other constant factor which is coming in between. Okay, so let's talk one by one. So I will be talking about resistance, I will be talking about reactance. Let's first talk about resistance. Airway, lung, resistance 5 Hertz frequency started, went inside. So the resistance measured at 5 Hertz frequency is labeled as R5. What does R5 means? Resistance measured at 5 frequency. That means it is measuring you, it is giving you the resistance from top to bottom, from the upper airway to the lower airway, or the total airway. So R5 means total airway resistance. This is total airway resistance, correct? If you are measuring R19 or R20, whatsoever, whether you are using FOT or IUS, they both are okay. So R19 or R20, this is a large airway resistance. R19 or R20, this is a large airway resistance. And what is small airway resistance or peripheral airway resistance? It is R5 minus R20. If you simply do a mathematics R5 minus R20, this becomes small airway resistance. Okay, done. Move further. Clear na? Yahan tak clear hai? So, in case of, if I want to make a table R5, R19 or 20, R5 minus R19 or 20, and if I keep normal person, this will be normal, normal, normal. If I keep large airway obstruction, what will happen to this? R5, what will happen? Very good. At least somebody is not sleeping. R1920, what will happen? Increase. Very good. What will happen to R5 minus R19? Normal, because it is a large airway resistance. If we are talking about small airway, then at that time what will happen to R5? Very good. This one? Normal. Normal, and this will increase. Combined obstruction, large plus small. What will happen? R5 will increase more, R20 will increase some, and R5 minus R20 will increase some. Done? Resistance clear? No doubt? Should we move to the next now? Great. So another way of depicting resistance on the graph is that you will get a lot of graphs and papers. So on the y-axis and on the x-axis. On the x-axis you will get frequency. This could be 5, 10, 15, 20. On the y-axis you will get resistance. So physiologically in children, they will be having some component of small airway problem or small airway resistance, because small airway contributes something. So physiologically in children, R5 is a little higher as compared to R20. This is physiological, correct? And if you are having, you can say like a large airway problem, then at that time this will increase and this will also increase. So this will become like this. Is it okay? Large airway? Perfect. Black line is large airway, black dotted line. Red line is? What is red line showing? What is red line interpretation? Black line interpretation, large airway obstruction. Red line interpretation, small airway obstruction. All done? Clear now? Perfect. Very good. And if it is a combined one, then it will come like this. So the magnitude of this will be more than this. So we see the magnitude, that absolute magnitude change in R5 versus absolute magnitude change in R5 minus R20, and that will actually tell us that which particular portion we are talking about. Is it okay? Should we move further? So this is resistance. Now coming to the next part, which is reactance. Now try and imagine that air has gone in, the lungs have inflated. When the lungs have inflated, now lungs have their own elastic recoil, or also called as compliance. So can anybody tell me what is, have you heard the name elasticity and compliance? Have you heard that name? Yes or no, yeah? Yes. You have heard? Correct. What is elasticity? Yes, ma'am. What is elasticity? Ability to expand. Somebody wants to correct her? Perfect. Come back to the original shape. This is important. So elasticity means you have stretched something and it come back to its normal shape. What is compliance? Compliance means accommodate. Ability to accommodate. Right. For an example, if I ask her to do something, she will say yes sir. Yes sir. Whatever I ask her, she will very compliant lady. Yes sir. Okay. If I ask him to do something, he will ask me 100 questions. And after that he might do it, he might not do it. Right? Very rigid. Okay, what I'm saying. So, compliance and elasticity are opposite of each other. ये क्या है? ये इलास्टिक है क्या कंप्लाइंट है? ये इलास्टिक है क्या कंप्लाइंट है? ये इलास्टिक है. Highly elastic. It is resisting the change. So elasticity means it want to remain in the neutral position. It do not want to change. If you are changing something, it is coming back. If you are changing something, it is coming back. Right? It do not want to change. This is highly elastic. This is highly elastic. So plasticity is the extended end of elasticity. It do not want to change. This is highly elastic. Compliance is something like a floor do. So now, in case of lungs, healthy lung, they are having normal compliance. Suppose if the lungs get pneumonia, lungs get respiratory distress, respiratory disease, fibrosis, what happens? Compliance reduces, elasticity increases. Elasticity increases means they become like a stone, they are not moving. They become like a stone, they are not moving. Elasticity increases. You understood what I am saying? Pneumonia, ARDS, highly membrane disease, the lungs have become stiff. The lungs are not moving. This has become stiff. It is not moving. Highly elastic. Very bad compliance. Very low compliance. Now the same concept we are going to use in the reactance part, which is X, denoted by X. So this is reactance, also denoted by X. Now, when the air is going inside the alveoli, and after that, depending upon the elasticity or the capacitance or the compliance of the alveoli, now it will rebound back. It will rebound back. When it will rebound back, so that means the reactance or the reactivity of that particular lung will decide about X. Because the reactance is a rebound phenomena, it is happening in the negative direction, it is happening in the opposite direction, and that is why it starts below zero line. So this is X, this is zero line, it starts here. It goes like this. So this is frequency 5, 10, 15, 20. Which particular wavelength goes till the alveoli? 5 Hertz. Correct, na? So 5 Hertz will be depicting you the reactance. 20 will not be able to depict you the reactance. So at 5 Hertz it will be negative, whereas by 20 you will not be seeing any reactance. So that is why in the lower frequencies it will start from the minus and thereafter it will move towards plus. Okay? So this reactance is basically having two components. One is called as capacitance or compliance, which is actually based upon the compliance or the elasticity of the system, which is a negative force which is happening. And the second component is inertance. or the inertia. So inertance or the inertia is from the middle airway, is moving up and up, up and up, up and up, up and up. So the peripheral airways are very much stiff, upper one a little less stiff, upper one a little less stiff, upper one a little less stiff. So his resonant frequency is moving towards right. It is getting shifted towards right. When the lungs are becoming better, then at that time the reversal will happen. So this resonant frequency in case of a bad lung will be shifted towards right. When the disease pathology will start reversing, it will shift towards left. Am I okay, or should I repeat it? No, not getting? Okay. Let's understand it in a different way. What is inertia? What is inertial force, anyone? What is inertia? Definition of inertia. Meaning of inertia. Yes. So inertia means that suppose if something which is in a particular motion, and if you want to stop it or you want to change the shape of that or state of that, then how much force you need to apply. For an example, if a bus is going on, a cycle is going on, and they both are moving, and you want to stop both of them, which one will take more effort to stop? Bus will take. So inertia will depend upon the mass. More mass, more inertia. If both are in the steady state and you want to push them to move, which will take more effort? Bus will take more effort. So inertia will depend upon the mass. Inertia is directly proportional to the mass of the object. So which is having more mass of the air? Middle size airway or large size airway versus small size airway? Middle size airway are having more air flow. More air is moving, more mass is moving there. So the inertia is more in the large airway and middle airway as compared to small airway. So that is why here in these higher frequencies, which are depicting of large airways and middle size airway, inertia is positive. In the smaller airways, the mass movement is not that much as compared to the elastic recoil. Elastic recoil forces are predominant in the smaller airways. When they are predominant in the smaller airways, so they are recoiling back. When they are recoiling back, so capacitive forces or the elastic forces are predominating in the smaller airways. And when these two forces, positive and negative forces, are equating each other, this is called as resonant frequency, FRES. Okay? Now this resonant frequency is very important because this elastic force and inertial force, they all are relative in a given patient, depending upon the disease status. Right now, the patient is severely asthmatic. So his resonant frequency will be shifted towards right. When the asthma will become better and better, then at that particular time, it will once again shift back to the normal. So more the diseased lung, whether obstructive or restrictive, this resonant frequency will shift towards right because it will occupy more inertial space. The capacitive forces will predominate in that. Smaller airway problems will predominate in that. You correct it and then at that time it will reverse. I will explain it later on also once again. But for now, you need to really understand that reactance means it is the elastic recoil, it is a negative one. Correct? So this is denoted by X. So for an example, if it is -2, this is -1, this is -3, this is -4, -5 for an example. So suppose if a patient with asthma or any particular disease came to you, you performed oscillometry and the X value came out to be, at 5 Hz came out to be -5 here. You gave bronchodilator and it reversed. That means from -5 it became -2. So the patient has got bronchodilator reversibility. So this was here. You gave bronchodilator, it reversed. So the resonant frequency is shifted towards left. X5 has become less negative. So though the value of -2 is more than -5, but there is a mathematical calculation. So just forget the minus, only keep the absolute value. Absolute value 5 is more than 2. So from more negative, it became less negative. So this is basically the principle in the reactance. So if I combine this reactance values to once again the disease pathology, is it clear or not? Yes or no? Yes. Okay. So if I want to once again say reactance at 5 Hz, resonant frequency is called as FRES, and area under the curve. What is the area under the curve? This is the graph. This is the graph जो हमने पहले बनाया था. and this is the area under the curve, which is also called as AX, or the reactance area. So, normal condition, this will remain, everything will remain normal. This is easy. Suppose if it is a large airway obstruction, once again they all will be normal because they are the parameter for the small airway. They are not telling you the large airway, so they all will become normal. Small airway obstruction, small airway obstruction. Now what will happen? X5 will become more negative, it will go down. I just have shown you, X5 will become more negative, it will start from here. When it will start from here and it moves like this, so resonant frequency will shift towards right. So resonant frequency will shift towards right. And when all this is happening, so this area is increased. So the area under the curve increases. Is it okay? Are you able to get it now? So the X5 became more negative, this is right and this is like this. Resonant frequency will move towards right and area under the curve will increase. In case of restrictive diseases, once again same pattern. This will move towards negative, right and here. Now, if anybody is not clear, please tell me. I will once again explain.
Restrictive.
Right. So the question is that why in obstruction and restriction the pattern is coming similar, right? This is the question. Because I told you similar pattern, why this is happening in obstruction and restriction? Very good question. That means you are still trying to understand. Those who are saying that they have understood, they have actually lost somewhere in between. And that is why you have not asked this question. Let's first try and understand restrictive disease. This is the lung. Let's take an example of 3 alveoli. 1 alveoli, 2 alveoli, 3 alveoli. Correct? Now in restrictive disease, what is happening? In normal condition, all the 3 alveoli are taking part. When all the 3 alveoli are taking part, then at that time the graph is normal. Let's assume the first graph is normal. This upper graph is normal. This is the normal graph which is giving you the report. यहाँ तक क्लियर है? ये बताओ पहले. नॉर्मल वाला ग्राफ क्लियर है कि नहीं है? नॉर्मल ग्राफ क्लियर है कि नहीं है तो बोलो. ठीक है? अच्छा. Now what happened? Now this lung became fibrosed. There are certain alveoli which are not participating. So only few alveoli are participating and the lung has become really very stiff. Correct? बैडमिंटन खेला है, रैकेट खेला है. जब न्यू बैडमिंटन लेके आते हैं, when we get a new racket, then at that time the wires are very stiff. So you hit with a less force, the shuttle will go farther away because the wires are very stiff. After a few months, the wires loose down. When the wires loose down, now at that particular time, the force is not that much by the wires because the wires have loosened up. So more the stiff one, more force will be generated. So more stiff the lung, more higher elastic recoil will be there. More higher negative force will be there. So it will start more negative. So it will start from more negative direction. Instead of 2, it will become 4 or 5 or 6. So it will start more negative. More higher force will be generated. So that is why this X5 will become more negative. Area under the curve will increase and resonant frequency will move towards right. So in restrictive diseases, is it clear? In restrictive diseases, X5 will drop further down. It will become more negative. Resonant frequency will move towards right and area under the curve will become increase. Done? Restrictive disease okay? Coming to obstructive disease. Another graph. This is one alveoli, this is second alveoli, this is third alveoli. Now there is some obstruction which has happened, could be because of asthma, because of any reason. And because of this obstruction is happening. Now this obstruction is usually up till the type in which it is that asthma is basically expiratory obstruction. That the alveoli is inflated, but it is unable to deflate. So this alveoli will start inflate, and ultimately what will happen, that this hyperinflated airway, hyperinflated lung will start pressing the normal alveoli. And when it starts pressing the normal alveoli, so the normal alveoli will behave like restrictive disease because the normal alveoli are unable to expand up till the normal extent. So ultimately, physiologically, the response will be same, like that of the restrictive disease. As in restriction, they were unable to expand. Here in obstruction, that part in which there is an obstruction, this is not participating because there is an obstruction. The signal is not going inside, that is not participating. But it is not letting the others to participate also. Because of its own hyperinflation, it is inflating, and that is why others are pushed, and when others are pushed, so they behave like restrictive disease. Is it okay? And that is why the pattern is similar in both the ways. Yes, sir?
So it's not a mechanical kind of obstruction. So it's a variable obstruction.
Yes.
So whether the air will go inside and there will be air trapping, and there will be more volume inside the alveoli.
Absolutely.
So
same thing. The same thing I told, which you told, that it absolutely it is a variable obstruction. So during inspiration the air is moving in, but during expiration it is unable to come out. When it is unable to come out, so there is more air trapping which is happening in the affected alveoli. She told a very beautiful word in the morning, heterogeneous. Heterogeneous means there are certain alveoli which are affected, there are certain alveoli which are not affected. Those which are affected, they are also affected over a different degree of obstruction, mild, moderate and severe. So it's not a homogeneous disease, it's a heterogeneous disease. When it is happening as a heterogeneous, then at that time, there are certain alveoli which are affected more as compared to other. Those which are affected more, they are getting hyperinflated. The PEEP is getting accumulated inside, which is called as auto-PEEP. It is getting inside. It is not letting the things to come out. When it is not letting the things to come out, the alveoli are getting inflated, and ultimately it is actually pressing on the side alveoli also. When they are pressing on the side alveoli, so the relatively normal alveoli, the side alveoli, they behave like restrictive. They are unable to expand. And that is why the physiologically it becomes equivalent to restrictive disease. Is it clear? So the last flow chart which I will now explain to you, that we will combine now everything together. So here I will make one table which is combined, and I will make one graph which is combined for everything. So we read parameters R5, R20, R5 minus R20, X5, resonant frequency and area under the curve. Normal condition, all are normal. Large airway obstruction, increase, normal. Okay, fine. Small airway obstruction, increase, normal, increase, more negative. Down arrow means more negative. Absolute value will increase, but because it is getting in the negative direction, that's why I'm saying more negative. Resonant frequency will move towards right, area under the curve will be more. Done? Combined obstruction, more increase, one part increase, down, out, up. Restriction, normal, down, out, up. Am I okay here? Oscillometry clubbed, everything done? Now I will put everything together in the graph, and that's done. So single graph, y-axis resistance, x-axis frequency. 5, 10, 15, 20. Whatsoever is above the baseline is resistance, below the baseline is reactance. Right? Let's first draw normal. This is normal. This is normal. Done? Now, I will draw the graph and you tell me that what it is happening. What is this red line depicting? Large airway, and no change in the reactance. No change in the reactance. Done? Very good. What is blue line depicting? Small airway. Done, huh? So small airway you can visualize from above also and you can visualize from below also. Same thing. And if you want to combine everything together, let's combine. So dotted black line. What is dotted black line? Dotted black line is? Dotted black line is? आप ठीक कह रहे हो बोलो? Combined airway obstruction, not complete, combined. Combined means there is a large component of large and the component of large is this much from the baseline and the component of large is this much and plus whatsoever extra is small. So this one was large and this extra is small and similarly the effect was there in the small. And if it is only restrictive, then there will be no changes above. It is only here. Changes will be there, but there will be no changes above. So this is a combination of everything. Any questions? This is the simple oscillometry. Complications start after this. I am not lending you in the complications now. So I'm just keeping it to you very simple, right? Any questions? All done? All done? So now the complication, one complication only I will just tell you, only one, not more than that, right? So now I have told you this graph like this. This graph I have told you like this, right? These type of graphs I have told you. Now when you are going to read the research papers, so researchers or scientists are usually, you can say, like crazy people, okay? They are not the very, you can say, like nice people like Dr. Balachandra or Dr. Manjunath. They are really crazy people, okay? What they do is that they try to create something different, okay? Same thing, but they will not say it's same. They will say in a different manner. So they will just rotate everything. So you will see the paper and you will see what is happening. So you will find a graph like this in which this is happening. So now the x-axis has become y and y-axis has become x. So this is the resistance in which on this side is the resistance, this side is the reactance, this side is the frequency. And now they will draw it like this and they will draw it like this. Same thing. So don't get worried. Wherever you will find oscillometry, the graph will be exactly same. You have to just rotate your tablet, that's all. So they will just rotate it so that to avoid plagiarism, that's all. Okay, so don't be worried about that. Okay? Anything else? No questions. Very good. Very nice. ये बेस्ट लेक्चर होता है. इसका मतलब ये कुछ किया तो कुछ समझ में नहीं आया, ये सब समझ में आ गया. अब ऑसिलोमेट्री में सेकंड पॉसिबिलिटी बहुत ही कम है. हाँ? हाँ. I told you that he is very elastic. I told you he is very elastic. Yes, sir. Please go on.
That last one, restrictive, नीचे का जो दो dot lines, what do you mean that one?
So basically, restrictive means that there is no problem in the large airway. When there is no problem in the large airway, so R will remain okay. There will be no change in the R. And the lung is getting stiff. When the lung is getting stiff, the reactance is affected. Reactance is affected, so X5 will go down. Resonant frequency will move towards right. And then area under the curve will increase. So one question which you have not asked is, what is the reversibility cutoff? Bronchodilator reversibility cutoff. 10%, 12%, which sir was asking earlier, na? So just to sum up that, so as per the ERS guideline, the reversibility cutoff for, so the most sensitive parameter is area under the curve. So the standard cutoff for reversibility is 80% in AX. This is the most sensitive parameter. The second sensitive parameter is X5 and the third sensitive parameter is R5. So X5 reversibility cutoff is 50 and R5 reversibility cutoff is 40. So this is the standard cutoff values by ERS, which have been published in 2020. Okay. Now these values we seldom get in clinical practice. So the workable clinical parameters are, we require more studies today, but this is somewhere around 50, this is 35 to 40, and this is around 25. So in majority of the reports, you will get these type of cutoffs, 50, 35, 40 or 25, rather than this one. Nothing else? Thank you. Have a happy lunch.
First thing is, we need more teachers like you.
Yes, sir.
First thing is, we need more teachers like you. And second thing is, there is always this argument that we do not have enough of reference values to corroborate with the clinical relevance. How do we answer that question, sir?
Yeah, right. So very nice question. But what I always say is that reference values, who are going to produce? You and me. We should make the effort. Like I am right now using different machines. I am doing some school studies also with Thermoflow machine to produce reference values. I am involved in certain studies. Even I am using oscillometry for different other parameters also. One of the common use for oscillometry with me is those children with neuromuscular disorders. We usually conduct some health camps with the genetic department of spinal muscular atrophy. So I'm having a good number of data, good number of patients' data of oscillometry in spinal muscular atrophy. I am unable to get this type of data from anywhere. I am right now writing that paper, but this will be good data. So if we can collate with the multicentric thing, you also do some study, he also do some study, and with all these studies we can collate our data and the references will come.
Okay.
So we actually require that effort, that's all. References will not come from somebody else. If somebody else will produce the references, then once again we will ask the question, oh, this is not from India. Who is going to bring from India? We are going to bring. So we have to make that point.
That's one thing. So second thing is, we have spoken so much about, say, 80%, 60, 80%, less than that. How much will we be able to grade in oscillometry? Do we have those reference values?
So there are no references, but with personal experience I will tell you. So the personal experience in pediatric age group are 5 values. Normal child, they are somewhere around 5. 4, 5, somewhere around 5 normal child. 5 to 10, I usually consider it mild. 10 to 15, I usually consider it moderate. And more than 15, I usually consider it severe obstruction. What is the rationale behind it? I am using a machine called Biotronics. In this Biotronics machine, the maximum resistance with PRN frequency, PRN mode, which I told you, that is multiple frequencies going in, coming out, it can measure only until 50. Suppose if the resistance is too high, the airway is too tight, then at that time the multiple frequencies cannot go in simultaneously. So machine refuses. Machine says that airway resistance is more, I cannot measure. Then at that time I have to change the frequency mode to mono frequency. When I change it to mono frequency, then either 5 Hz or 8 Hz goes in and come out. So that happens after resistance value 15. So that is why I consider that cutoff as a severe. If the machine is, I have to change the mode to mono, that is severe. And 10 to 15 is moderate, 5 to 10 is severe.
Thank you so much, sir. Thank you. And we'll break for lunch.